So it can present in sort of the classic presentation of these lichenoid papules and plaques, where you're seeing hyperpigmented and violaceous, pruritic papules. But it can also present at a later stage with sort of depigmented patches, which almost look like vitiligo-like depigmentation.
That's Dr. Neda Elbuluk, and this is Dermatology Weekly, the weekly podcast from MD Edge Dermatology. I'm MD Edge editor Elizabeth Mishkati.
And I'm MD Edge editor Terry Rudd. Today, vitiligo isn't the only condition that can lead to depigmentation. There are other conditions that dermatologists see less commonly that can result in vitiligo-like depigmentation, such as photolichenoid dermatitis. Dr. Vincent DeLeo talks with Dr. Neda Elbuluk about the common causes and clinical presentation of photolichenoid dermatitis. And Dr. Elbuluk emphasizes the importance of screening for underlying medical conditions by describing a case of a photolichenoid eruption in a patient with undiagnosed HIV.
In the news, a study provides some reassurance about the safety of the live attenuated varicella vaccine in patients on TNF inhibitors. The American Academy of Dermatology and National Psoriasis Foundation have published the first guideline on pediatric psoriasis, and an expert provides recommendations on diagnosing and treating onychomycosis.
You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
And now the news.
Patients on a TNF inhibitor received the live attenuated varicella vaccine Zostavax without any cases of herpes zoster in the first 6 weeks after vaccination. Those study results were reported at the annual meeting of the American College of Rheumatology. The CDC's Advisory Committee on Immunization Practices says there's a theoretical concern that Zostavax could itself cause varicella infection in patients on TNF inhibitors and other biologic therapies. And patients with rheumatoid arthritis and psoriatic arthritis, who are likely to receive TNF inhibitor therapy, are also at risk for herpes zoster reactivation. But the randomized controlled VERVE trial may ease those fears. Researchers at the University of Alabama, Birmingham included 627 people aged at least 50 years who were taking a TNF inhibitor and hadn't previously received Zostavax. The anti-TNF agents used were adalimumab, infliximab, etanercept, golimumab, and certolizumab. Some patients were also on other treatments, such as oral glucocorticoids. The most common indications for TNF inhibitor treatment were rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. At 6 weeks, there were no confirmed varicella infections among the 317 vaccinated patients, and there was no difference in the rate of disease flares or in adverse reactions between groups, though the varicella group did see a higher rate of injection site reactions than the placebo group.
The American Academy of Dermatology and the National Psoriasis Foundation have issued guidelines on the management and treatment of pediatric psoriasis. Psoriasis affects about 1% of children, either alone or with comorbid conditions such as psoriatic arthritis. In the guideline, a multidisciplinary workgroup identified screening tools to measure disease severity, strategies for managing comorbidities, and the safety and effectiveness of different treatments. The guideline divides pediatric psoriasis treatment into 3 categories: topical, phototherapy and photochemotherapy, and non-biologic and biologic systemic treatments. This is the first time that pediatric psoriasis has been discussed as an independent topic within a guideline. That's according to one of the guideline authors, Dr. Dawn Davis, a pediatric dermatologist at the Mayo Clinic in Rochester, Minnesota. She's also the past president of the Society for Pediatric Dermatology. In an interview with MD Edge, she pointed out that children have unique physiology and psychosocial aspects to their care relative to adults. Dr. Davis explains that psoriasis can be a psychosocially debilitating disease. For example, isolated or prominent facial involvement is common in children, which can be embarrassing and impact their relationships. The take-home message for clinicians: keep in mind the multisystemic nature of psoriasis, which isn't limited to the skin. Treating a patient with psoriasis requires practicing whole-person care, and Dr. Davis says you must consider the multiple comorbidities that impact quality of life and overall health in children. The guideline is the latest in a series of joint AAD-MPF guidelines on psoriasis being published this year in the Journal of the American Academy of Dermatology.
There's no such thing as a classical presentation of onychomycosis. That's according to Dr. Neil Bhatia, Director of Clinical Dermatology Research at San Diego-based Therapeutics Clinical Research. He offered his tips for diagnosis and controlling recurrence at Skin Disease Education Foundation's annual Las Vegas Dermatology Seminar. For diagnosis, Dr. Bhatia says visual assessment has a sensitivity of 77% and a specificity of 47%. KOH staining has a sensitivity of between 67 and 93%, with a specificity between 38 and 78%. PCR, on the other hand, is quick but expensive, and it carries a high false positive rate. So, for difficult patients who aren't responding to treatment, Dr. Bhatia warns, don't trust your eyes alone. For controlling recurrence, Dr. Bhatia recommends using a topical antifungal twice a week for 2 to 3 years, as well as periodic application of a topical antifungal to the plantar surface and interdigital spaces. He also recommends treating immediate family members, decontaminating footwear and socks with antifungal powder, and avoiding communal swimming pools. Dr. Bhatia points out that for clinicians treating onychomycosis, the ultimate goal is no more fungus. But what some patients want is normal-looking nails. So, if you have a patient who sees 2/3 of her nail improve after 52 weeks of topical treatment, Dr. Bhatia says you're not going to say, stop, you're a failure now. Instead, tell your patient to keep going with treatment and that you'll keep watching. Dr. Bhatia emphasizes that it's very important to measure success based on what the patient's experiencing. Skin Disease Education Foundation and this news organization are owned by the same parent company. We'll be right back after this message. And now, Dr. Vincent DeLeo and Dr. Neda Elbuluk.
Today we're talking to Dr. Neda Elbuluk about photolichenoid dermatitis in an HIV-positive patient. Dr. Elbuluk is Clinical Assistant Professor and Founder and Director of the USC Skin of Color and Pigmentary Disorders Program in Los Angeles, California. She also is Founder and Director of the USC Diversity and Inclusion Program. Dr. Elbuluk previously was at the Ronald O. Perlman Department of Dermatology at the New York University School of Medicine in New York City. Dr. Elbuluk, thank you for joining us today.
Thank you so much for having me.
So first, can you describe the histopathology in cases of lichenoid photodermatitis?
Sure, I'd love to. So essentially, the common findings on histopathology are a dense band-like lymphocytic infiltrate in your superficial papillary dermis abutting the epidermis, and with that comes an accompanying interface change at the DEJ. So typically you're going to see necrotic or dyskeratotic keratinocytes, and some of these can be found in the dermis as well, and you also see pigment incontinence from the melanophages that are in the papillary dermis as well. The infiltrate can sometimes have eosinophils, and it may or may not also have a deeper perivascular component.
Thank you for that. Photolichenoid dermatitis was first described in association with the treatment of malaria. Can you explain how its association with other medications has evolved?
Yeah, so over the years what's happened is that patients who've been found to have this diagnosis after being clinical evaluated and biopsied have had histories taken, and then there's been found to be this temporal association between certain medications that were taken and the photolichenoid eruption happening. So other medications that have been found to commonly cause these photolichenoid eruptions, particularly in those with HIV, include NSAIDs and Bactrim, which are probably the two most common, and then certain heart heart medications like sequinavir and efavirenz, and then other medications like dapsone, ketoconazole, and terfenadine. And there's a nice review paper that actually discussed a lot of these by Dr. Berger's group in the early 90s. So these are the most common medications that we typically find can be associated.
You discussed the literature in photosensitive conditions in patients with HIV, including your patient with the photolichenoid eruption. Can you discuss the various clinical presentations of photosensitivity in HIV patients like you do in your article?
Sure. So, the clinical presentation can vary. So it can present in sort of the classic presentation of these lichenoid papules and plaques where you're seeing hyperpigmented and violaceous, pruritic papules. But it can also present at a later stage with sort of depigmented patches, which almost look like vitiligo-like depigmentation. But one of the marked differences is that the depigmented patches tend to be erythematous, and they tend to have very fine scale, either overlying them or with a coloritive scale. These manifestations also occur in a photodistributed manner. So those are a few things clinically that I think make it unique. A few other things that I'll just mention in the literature related to this diagnosis in these patients are that in general, about 5% of HIV-positive patients are found to have photosensitivity. But these patients in particular who are getting these photolichenoid eruptions, including our patient, typically have advanced HIV or even have gone on to develop AIDS and tend to have a very low CD4 count. So in the literature, it'll say below 200, but even more often than not, it's less than 50. And what's really interesting is that we found that this condition tends to occur more commonly in those of Black descent and Native American descent. So one study even showed that it's up to 7 times higher risk in a Black person compared to a Caucasian person. And the other thing that's of interest is that although this can be associated with taking a photosensitive medication, it's not required. So similar to our patient in this paper, you can have these individuals with HIV who present with these manifestations but never took a photosensitizing medication. So it's very fascinating, and it's a small subset of individuals that it occurs in, but I think it's important for physicians to be aware of how it can present clinically and how we can be helpful in that management and workup.
So you point out in your article that many times the photosensitivity predates the diagnosis of HIV. So what kind of workup do you recommend when a patient comes in cold with a photolichenoid dermatitis?
Yeah, so I think if clinically it looks like they have a photolichenoid eruption, the first thing you want to do for sure is to biopsy it, just to ensure that's really what it is. When our patient came in, actually we were worried more about discoid lupus. That was the first thing that came to mind. So as part of that, we had ordered an ANA. Other laboratory workup, though, should include HIV as well as a hepatitis panel. I would say any additional workup beyond that would only be based on your differential and if there's other things that you're considering. But I think that's a good baseline workup for these patients.
And as we were just discussing, that this eruption can occur in a patient who is not yet diagnosed with HIV. How do you approach that issue? How would you recommend to your colleagues to approach patients in that setting?
Yeah, so I think this is a really good case and example of how we as dermatologists can be so instrumental in diagnosing internal disease. And, someone who comes in with this sort of presentation of this photodistributed eruption that either is more lichenoid or presenting with depigmentation, I think it needs to be in the back of our minds that there's a potential that this individual could have HIV. You could start with just screening questions about, sexual history and if they've ever been tested and so forth. And then I think it's reasonable to tell the patient that along with doing a biopsy, there's some additional blood work to test for conditions that can be associated with these kind of eruptions, one of which would be checking for HIV. And so when we sort of present in that manner to our patient, he, didn't really have any issue with it. And actually it was good that we were able to uncover that diagnosis because we were the ones to actually refer him to the ID clinic and to get him started on heart therapy.
So I think this is a very interesting case. And as you just pointed out, it's important for dermatologists to always be thinking about the general health of our patients when we see them and consider all of the possibilities in these individuals, including HIV. So, Dr. Elbuluk, I was wondering if you might discuss for our listeners what you're doing at USC in the Skin of Color and Pigmentary Disorders program.
So what we're creating is sort of a multifaceted program where we are building out both medical and procedural clinics that have a focus on disorders that disproportionately affect ethnic skin, as well as pigmentary disorders, which can happen in all skin colors but are more common in ethnic skin types. And so we have specialty clinics for those patients, as I mentioned, on the medical side, but we also have procedural clinics for doing procedures that can be safely and effectively done in darker skin types. And that's sort of all on the clinical side. On the research side, we're building a research program, and we now have a research fellowship associated with the program where we're focusing on studying these diseases and conditions in more depth, and we're doing different clinical and translational studies in collaboration with colleagues at other departments as well. And it's really been a very rewarding and exciting experience to be building it up, in Los Angeles, which is the second largest city in the U.S., but actually one of the most diverse cities. We have the largest African American, Hispanic, and Native American community in the country. So we're really in a hub of diversity here, and it's really wonderful to be able to cater to this population and their unique needs. And Dr. DeLeo was really the pioneer in starting the Skin of Color Center with Dr. Susan Taylor back at St. Luke's several years back. So since then, we have about 10 clinics / programs across the country with an emphasis in skin of color, and some of them also looking at pigmentary disorders. So I think hopefully over time we're going to see more of these come up across the country, because I think we really need it, and the U.S. population is continuing to diversify.
That's great. And you were talking about your fellowship. So what types of our listeners who might be interested, what level of training are you looking for in your fellows?
Yeah, so the fellows are in medical school typically, and they are often taking a year off between their third and fourth year, but could also be open to those between their second and third year. In theory, we also could take fellows who are individuals that have finished medical school and possibly have time either after intern year, before intern year. But you have to sort of be at least halfway through medical school to do the fellowship, and it's about a 1-year time frame.
So any other comments that you'd like to make about your patient or about this area in general?
I think it's fascinating just to, see patients like this who remind us that depigmentation or pigmentary changes can represent or be associated with underlying medical conditions. And I think a lot of times when we see depigmentation, first thing that comes to mind is vitiligo. But, there are other conditions that we see less commonly that can sometimes result in vitiligo-like depigmentation. And so I think just keeping that kind of differential in the back of our mind is really important, just so we don't miss important underlying diagnoses such as HIV.
So we want to thank you for taking your time today to discuss this with us, and hope that everything is going well in your new position at USC. I'm happy to have a colleague at our institution with your expertise. So thank you for joining us today.
Thank you so much, Dr. DeLeo. It's been a pleasure, and I appreciate you highlighting this important case.
And that concludes this week's episode of Dermatology Weekly. To get past and future episodes of Dermatology Weekly, subscribe now on Apple Podcasts, Google Podcasts, Spotify, YouTube, or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MD Edge editor Melissa Sears, and all of us here at MD Edge, I'm Elizabeth Mishkati. Thanks for listening.